Repeated movement testing and repeated movement treatment for the diagnosis of joint derangement, like everything in medicine, has a specific dosage. And I'll go over that today and kind of how I explain it to patients in terms of why we apply the dosage that we do, which is frequently throughout the day. So repeated movement testing is my investigation into the diagnosis. And if there's rapid changes in symptoms and or mechanics, it largely implicates the joint mechanics. And if there's a movement that fixes it entirely, we call that a diagnosis of joint derangement. So it's in contrast to a ligament sprain, a muscle strain, a fracture, or any number of structural lesions or degenerative processes. Now, I would also add here that I think a lot of orthopedics is predicated on these, what I call stories, like IT band syndrome. I think they're missing the joint derangement and instead making up these kind of convoluted pathophysiological explanations for why someone has hip or lateral thigh or knee pain. So I find that 70 to 80% of patients have joint derangements, and the only reason I can find that is because in addition to quick orthopedic special tests if I need them, in addition to images if I need them, I use repeated movement testing as the third part of my orthopedic evaluation. So repeated movement testing for the dosage, not in the clinic, but if I continue the testing at home, which is a distinct process from what most orthopedic clinicians employ, I believe repeated movement testing means repeated. We move thousands of times per day. So if your knee moves thousands of times per day, for me to understand how that knee behaves, I need to move it hundreds or thousands of times in a specific direction to get my answer. So the dosage for testing when it comes to the home testing outside of the clinic is on average about 10 reps every 2 to 3 hours. So it's about a minimum of 6 times per day, and I'd love to see it 8 times per day. And there are obviously slight differences among different patient populations and individual patients, but that is on average what I'm prescribing as a form of testing. And some people might think of it as wishy-washy, but here's an analogy that might be helpful. If your clinician finds that you have a bacterial infection and you are given, and they think the bacterial infection is X, and so you're given antibiotic X, and the goal is to take that antibiotic every day and come back in a week, and the clinician can figure out what has happened to your infection. Say you don't take the antibiotic every day. Say you take it every 2 days, and you come back to the patient or the clinician's office, and the infection is still there. Well, then how can the clinician make the deduction whether or not it's the wrong antibiotic, whether something else in the prescription was wrong, or whether everything was right, it just wasn't taken as prescribed? Now, it's a little bit of a gray area whether or not that's testing or treatment, and I understand that. But so much of medicine is actually this: do this so we can figure out what happens. But in orthopedics, the mainstream paradigm is that on day one, we know what the diagnosis is. We take a picture that's very sophisticated, or we do quick clinical special tests like test the integrity of a ligament or test the integrity of a muscle. And therefore, you know the diagnosis on day one, and voila, you can start treatment on day one. And in some cases, that's absolutely the case. But in the vast majority of cases, I find you cannot make that diagnosis day one and be confident in it unless you do repeated movement testing, which takes a little bit longer, obviously, and becomes that gray area of, is this treatment or is this testing? So if I am curious if neck retraction will fix your shoulder problem, I'm doing some in the clinic that gives me confidence that we're on to something, that this is a joint derangement, or that I need to make sure that it isn't before I rule in tendinopathy of the supraspinatus, for example. If I see evidence in the clinic when we do 30 or 40 neck retractions and there are changes in the shoulder symptoms and or shoulder baselines, or maybe just in the neck baseline sometimes, I'm going to have that testing completed and continued at home for several days. And how long I decide to see that testing through is dependent on the patient's presentation. For instance, if the shoulder pain has been there for 10 years, I probably need more reps to figure this out. If the shoulder pain is a week old, I don't need more than 24 or 48 hours to be convinced that neck retraction is the way to go or not. And if it's not, then we move on to different testing. So if I find that the diagnosis is joint derangement, then the treatment becomes, once we've found that directional preference for the joint, the movement that, when done repeatedly, fixes signs and symptoms, the treatment dosage is going to be about the same. Now, certain people can probably get away with a little bit less as they get better and better, but that dosage is still frequent. And I've had patients come back and misunderstand, or I wasn't clear about the dosage, and so they come back and they say, Laura, I did 100 in the morning. And that doesn't cut it. It needs to be 10 every few hours. If something's tweaked in my joints, I'm doing it regularly. I'm not waiting, because that regular kind of stimulus is important. And how I describe it to patients is kind of like this. If your joint's not moving well, at 8 a.m., you push the boulder a little bit up the hill. And by 10 o'clock or 11 o'clock, you're going to move that joint in lots of different ways. Even if you're just lying down, you might not be moving it in lots of different ways, but it's getting a different load than what your directional preference that we're testing is. So by 10 or 11, it's going to come back down a little bit. And then at 10 or 11, you're going to do another set of 10, and it's going to go back up to here, and then it's going to come down a little bit. And then it's go up to here, and then it's going to come down a little bit. And eventually, we'll get it to where that joint needs to be, where it's stable and functioning well, and signs and symptoms are abolished. So again, if you do 100 in the morning, you might push it up to here because you did 100 and not just 10 repetitions, but it'll slide back to here, or maybe even more, because you're going to have 24 hours before you do it again. And so then it's going to take longer to do it, and it's probably not going to be fruitful. And if you're not seeing changes on a regular basis, people are likely to not believe in this or discontinue the investigation. And I get that. So it's my job as a clinician to point out the importance of the dosage. So unlike muscle strengthening, which could be doing 3 sets a week for your training, or unlike stretching or PNF patterns to elongate or increase a muscle's range of motion, a muscle's flexibility, that might be once a day or twice a day. And so different treatments, different pathologies require different dosages. And so this, while it may be only 5 or 10 or 15 minutes of a patient's day in terms of their rehabilitation, which is less than a lot of rehabilitation protocols, the frequency throughout the day is what becomes challenging for patients. So it's my job to educate the patient on the dosage, like I said, but it's also important for me to show that there's some effectiveness, because I need that patient to understand, hey, when I do this motion, this gets better. And if they can see that, they're more likely kind of psychologically to be on board with the dosage every couple hours. For neck patients, it's quite easy. You're seated. For most of the neck exercises I prescribe, it takes 30 seconds to a minute to do it. Doing that 8 times a day is super easy. For low backs, it can be a little bit more challenging if we're getting to less commonly used exercises. But again, pushing the boulder up the hill is kind of the analogy I like to use when it comes to dosage. And it's really important to get this right, because if you don't understand this and you think, oh, she said I have a joint derangement, I need to move into knee flexion, and you do it a couple times a day, or you do it heaps of repetitions once a day and you don't see change, you might discount it. But I would say, well, you're not employing the dosage correctly.